Welcome to our conversation tonight about senior care and what the options are out there for people. And so we're just letting people jump in here, and I'm seeing the attendees filling up. So welcome to our webinar on becoming a senior and what options are available in BC. And so Mark and I at Driediger Wealth Planning, we are, many of you are our clients, some of you are not, but we work as financial advisors here in the community. And one of the things that we do is we look at all areas of your life. And so in the last couple of years, what we have noticed is that so many of our client conversations has been revolving around, what do we do? I'm not able to maintain my home anymore, or I have had an illness and I can't be at home. What does that look like? Or we have adult children who are going, my parents can't care for themselves, but they want to stay at home. What does that look like? And how do I talk to them about this? And so Mark and I both agreed that it was time that we maybe put something more formal together to have a conversation. And so hopefully at the end of this this hour together that we would be able to have shed light on what options are available and how some of the best practices for you to walk this out. And so my name is Brent Driediger. If you don't know me, I work with Driediger Wealth Planning. And Mark, why don't you introduce yourself?
Yeah, Mark Driediger, and Brent and I are partners in our financial planning practice here in Abbotsford. And we are delighted to be able to spend the next 50 minutes or so going through this understanding of senior care. And we're very pleased to have Skeels from the care group based here in Abbotsford as a social worker at the Mayfair, or the old Ebenezer site, as some might be familiar with. And so she's the expert. I understand a fair bit of this because I've walked this out both within our own family and with clients. But there's a bunch of pieces of interfacing between families and the government system, and Monica is going to have some insight into that. Monica won't have all the answers, but she's going to have many of them. And so we're looking forward to that. And so we sent out in the invite, we had the things that we're going to be really talking about tonight. And we really want to demystify some of the jargon that happens around senior care, what happens in different levels of senior care, some of the financial aspects of what does all this cost, and I hear that I can get private and there's public, and how is this calculated, and then talking most importantly perhaps at the end, is really around critical conversations to have with loved ones about making everybody sure of in the family about what does the senior want or the parent want, and what are some of the best practices that families can take as a group to have great outcomes in the latter stages of a senior's life. And I'm paying careful attention. I hope my kids are too, about me, because eventually this is my lot. I'll be there too. And we want to do this really well. And so that's the format. And then at the end, we'd like to spend a few minutes if there's any Q&A questions. We would like to, in the chat on the side, there's a place that you can put them in, and we will field, if there's any questions, we're happy to field them. And at the end, this is recorded. And so if we want to pass this along to anybody, and there's some resources at the end, we're happy to get that passed along as well. So Monica, why don't you introduce yourself, and then we'll get going here.
Yeah, well, my name, like he said, is Monica, and I'm a social worker right here at Mayfair in town. And I've worked in long-term care for a number of years. I have also worked in the hospital. So I've worked in the community actually as well. So I've kind of been there and from each different kind of angle over the past decades, which I don't want to mention. Yeah, so I kind of come at it, and I've also had it in my family as well. So I kind of I've been there in a lot of different perspectives. So, yeah.
Great. Okay, so why don't we start going through our the deck, Brent? And so why don't we pull up? So what we're going to do here is just sort of talk about specifically, there's sort of really 5 levels of healthcare, or of seniors care. And so what we want to do is walk you all through that and talk about how, like this, as it says, how does Fraser Health fit into this, and what should be considered. And so what we want to do is talk about really the 5 care levels that exist out today, and that would be through home health care, and then the independent living, and the assisted living, long-term care, and behavioral care. And we won't spend too much time on the last one, but those are the ones we want to have a look at. So as we talk about home care and what to expect, Monica, why don't we start there? And can you unpack that a little bit for us?
Well, home health care is kind of an umbrella for a bunch of different supports, from in-home care, like home supports, and they also have they're called community health nurses right now, CHNs we call them. Their name changes once in a while, but they also do the assessments for government subsidized facility care, for the assisted living and for the long-term care. So so those community health nurses are really a key player in this whole field of senior care for when they're not managing on their own at home anymore. So that's a big piece of the puzzle.
Okay. And with home care, when we think about that, that's really around, I'm living still independently in my place, but in my own home, my own residence, but I need somebody to come in to help maybe 2 or 3 times a week. And what are the options around that one?
Yeah, again, it depends on the assessment, but there are certainly different options available. There are options for personal care. That's kind of one of the base requirements to qualify for the government subsidized home support through home health care, actually. They can also provide respite relief if there's a caregiver at home, like say it's a elderly couple, and the one is still doing okay, but can't provide the personal care anymore for the other one. So that's a typical example of when home health care would come in. And then they can also provide respite care for the senior that's doing okay, but doesn't want to leave the spouse alone at home. So that respite care can look like 3 hours once a week, something like that, where the one spouse can go and get groceries and just even go meet someone for coffee, get a bit of a break. So those are a couple examples of what they can provide.
And is that a funded thing, or is the senior paying for that? How does that work?
That all depends. At the time of the assessment, the home care nurse also does a financial assessment. And basically, from what I gather, they're looking at line 236 on the notice of assessment from the income tax. And so they have sort of this fee scaled according to income. So some people don't pay anything if their income is below a certain number, and then people pay according to their income. And there is a ceiling on it, but it is according to your income.
Okay. Yeah. And these are listed, these are the items on the screen here. This is what that would be happening at the home. Could be happening there, or some variety of that.
Yeah, and depending on the situation, there are also some nurses that can come in depending on the situation, like for palliative care needs and things like that, medication at the end of life, sort of those sorts of stages. Then there are nurses as well as care aides.
Okay. And all of these ones that interface with the government or with Ministry of Health and Fraser Health, there's a 1-800 number at the end, which we're going to get to. You'll see that at the end. And it starts with a caseworker, and like that's the gateway into this system.
The service line, the home health service line. That's the first line of attack. That's a terrible phrase, but that's the first phone number to phone, and that's when you're phoning in a referral, and that's when that's a referral. And then later at some point, someone will get back to you. If you're in the hospital, on the other hand, they do have what's called a home health liaisons in the hospital. And that's often a first line of defense there.
Okay, then the next stage would be an independent living and community. And within Abbotsford, an example of that would be Primrose Gardens over in the Menno system. And it's an independent living. And what does that look like?
That's for somebody who doesn't qualify for any of the other levels of care yet, but they feel maybe that the home support is not quite enough for them at home. And they're managing, but they'd like to have a little bit more social, a little bit more community, and they would just feel a little bit better and maybe safer in more of an independent living situation. And in this independent living rooms, There are, like you've got mentioned there are kitchens, so people can still do their own meals if they want. Most independent livings do offer, I believe, at least one meal a day as well. So then they can have, they don't have to worry about the meals, and they can have the social component, which is really nice. And then again, most independent livings and some assisted livings too, they have these communal rooms where families can, they can rent those rooms and have family birthdays and have more people, involved at certain events, that sort of thing too, which is kind of a nice thing.
Okay.
Yeah.
And another example that would be Elam Hallmark would have this. That would be, so if anybody out there is trying to reference like what is this,
Yeah,
that would be it. And so it's a intermediate step between can't be at home anymore, but I'd like to be in that kind of community. Maybe you could, but you just want to be in a more community, and this is a step before we talk about it, or before you move into an assisted living.
And people can get some home support in independent living if they need as well.
Okay.
But yeah, you are definitely directing your own care, and you're able to live on your own still in independent living with some help if needed.
People are driving and have their car there and all that sort of stuff.
Totally. Yeah.
Okay. So the next would be the assisted living. So that's the next step.
Yeah. And you listed it out real nicely here, Mark. In assisted living, you're still meant to be able to direct your own care. So that's kind of the qualifier there. And I know sometimes it gets a little iffy when somebody's ready to move to the next stage. There can be a little bit of gray area there, but for the most part, you need to be able to still direct your own care there, be able to, like you've got it. I think I've read this earlier, you're able to call for help if you need it.
Mm-hmm.
You can manage your own meals, that sort of thing. They do offer more meals here, and they do have nursing care in assisted living, which is great. Your medication is dispensed for you. You don't have to worry about that. Yeah. So it's just a big step above independent living. And also for people who are living at home with home support, and depending on the situation, when it gets a little too hard for them to live with that sort of scenario, assisted living, sometimes people need assisted living, sometimes they need long-term care, depending on when they reach the end of that sort of phase. But sometimes people can move from living on their own with support into assisted living because there's just a little bit more support provided.
Yeah. Brent, you want to move to the next? Yeah, there. So
There
we
you
talked
go.
about eligibility criteria for assisted living. So let's talk about like when somebody would be really where they're like, what would be the markers for it?
Well, those are some of the critical ones that you've got listed right here. Home health clients, they can no longer, their needs can no longer be met at home. And they're able to communicate and be understood by others. They don't behave in ways that put the safety of others at risk. They're able to take direction in an emergency, and they're able to use an emergency response system. That's really critical. And that's a nice feature of assisted living, that if you're a couple and only one of you actually is eligible for assisted living, there is a possibility to move into, depending on the suites available in certain facilities. But those are kind of the key qualifiers right there.
Yeah, and there's a few other things too, like there's more bolt-on services, like depending on what you all need. Like if it turns out that you need to have diabetes management, medication that's delivered, staff for additional costs that can also be administered and taken care of. And you're right though, Monica, there's gray areas where there's not, like, boy, some days it looks like assisted living's good enough, and then there's other days it looks like full long-term care is, and there's a messy spot many times in between those two places.
Yeah, I lived it with my mother-in-law. It was a bit messy at the end, and I know I've heard other people too, but I think any time you've got the transition from no care to care, from care to independent to assisted, there, the transitions can be a little trickier to manage. But
okay.
So if this becomes too much, where your health has kind of outpaced some of these eligibility criteria, the next step is long-term care.
Is again the CHN, the community health nurse from home health. Yeah.
Yeah,
And this is a point I wanted to make at some point. Now is as good a time as any. I think it's really important for there to be an advocate for the family
absolutely.
member. I mean, gone are the days where, everybody's keeping an eye on everybody and there's somebody who's taking care of each step of the way and that sort of thing. Now, there's lots of situations where transitions and different processes go smoothly, but there's more cases than not where, hey, my mom's not managing well in assisted living. Can we, what's the next step? And then it's the community health nurse again at home health at that point to phone. And a lot of times the staff at the assisted livings are maybe even a step ahead and thinking, we can't manage, this isn't going well anymore. And they often will talk with the family and say, hey, we're going to be calling the community health nurse because it's not going as well. Your mother is not able to direct her own care anymore. She's getting a little more confused. There's lots of stories I can tell of my own mother-in-law. She was escaping and things like that, right? Like if you can direct your own level of care and you can still, take off and meet up with a family member at the door without, there's always signing out and that sort of thing. But if you lost that ability to sign out and you just think, oh, it's nice out there, I want to go outside and you get lost. It's clear then that assisted living is no longer meeting your needs. Yeah.
Okay, so the next level of care is long-term care, or also called residential living. And so those are interchangeable words. So let's unpack that. And this is the world you live in probably more than anything.
Yes, this is the world I live in. Yeah. So at this stage of the game, you need more care. It's one of two things. You either need more care than what assisted living can provide, or you can no longer direct your care and you need to be in long-term care. We more cases than not, we do see different levels of cognitive impairment in long-term care, but there's there's more so than it used to be in the past. But there's still at Mayfair we have several residents who are still very cognitive, and yet they are in full care because they can't meet their needs can't be met elsewhere. So, and then of course there's the private pay long-term care beds as well, which that's also an option for people too. Yeah.
Yeah, and we'll get to those two streams in just a second. So what could somebody moving into long-term care, this is people can read, but anything else to add like around this? It's 24-hour nursing care is available.
Yeah. Yeah. And all the personal care and assistance with all the activities of daily living are provided. Meal options, like you had mentioned earlier, in long-term care, it's all provided. If you need a special diet for diabetes, or you need a minced diet, it's all provided. There's a dietitian on staff. And just like in assisted living, there's a recreation department in most residential living situations as well, which is wonderful. And the rec staff really try to meet the needs of each resident, knowing that everybody is different, has a different level of ability and, all that sort of thing. So, laundry, hair care.
Yeah, and the other thing I noticed too is that we've got, there's physiotherapists who are around there,
and occupational therapists, which is great because they can assess for the equipment that you need. And if something's not working as well for you, they can even assess the equipment you have and recommend different other supports to be added to it. Or, they're invaluable for us in long-term care. Yeah, they are amazing.
Yeah. I think another interesting one is getting blood work done, or some of those basic medical things that you might need. Some of that stuff can be done in-house, and that's just a huge deal, especially if you've dealt with someone who's really struggling on the health side. To get them to an appointment to do those things actually is exhausting at some points. And so I think that's a great service
That's a very good point. And there's also physicians assigned to every resident in long-term care as well. Same thing. You don't have to go out to to make an appointment with your doctor. Doctor's right in-house and doesn't actually live in the
And I
facility,
think
but yeah.
they have care conferences too with the family and with the doctor and the key people in that long-term care.
Yeah.
From time to time, though, they're scheduled meetings, so family can be actually quite engaged in making sure that their
For sure. Family are considered a very key player in the care needs of the resident. They know the resident the best in most cases. So it's very important. Those care conferences happen every year and med reviews happen every year. So at least twice a year, there's a very formal official, licensing requires it, where we review the care plan and medications, make sure that we're not doing anything that's not necessary. You know, there's all sorts of goals in long-term care. One of them is to be on as few medications as possible. So that's kind of built into the whole process is there, protocols and stuff where, yeah, we're looking at that officially twice a year with the pharmacist on hand. And yeah.
Okay, and the last one, and there's no slide for it, but it's behavioral care. That's the sort of another level. You want to just explain that in a couple sentences, very short?
Sure. Yeah. Several of the long-term care facilities have what's called a behavior unit. And that's for residents that, yeah, they shouldn't be on just a regular unit, because a lot of times they're an elopement risk, or they have behaviors due to different stages of dementia and how that has impacted them, or different other diseases where they do maybe call out a bit more or have some behaviors that just need a little bit more monitoring. Yeah.
Okay. Great.
All right, so those are the different levels of care that are available. And so we thought it would be helpful to put together some examples of how do we get there? What are our options? And because this is like the classic test is your loved one has either, or yourself has now had a medical issue. How do we get assessed, and how do we end up choosing what is right for us? And so that's what the next slides are going to kind of go through for us, is how that works. So Mark, why don't you start with this one for us?
So in this example, because I think examples are pictures that we can paint for ourselves about something that's happened with a family member or a friend's parent, or maybe ourselves, and you're kind of like, oh, this is something is happening that's not working anymore. So what's the first thing? And as Monica said, the first call is calling for an assessment with Fraser Health. So in this case, Fraser Health, and hey, Monica, you can chime in here and cut me off if I get this wrong. So,
You're good.
So Fraser Health agrees that they need assistance. Then help may come to the resident's home, and then there's also there may or may not be a cost to that, and we're not going to unpack exactly what that is. Next one step is Fraser Health determines that you don't qualify for assistance, and we see that where the person maybe presents really well. It just doesn't really seem like there's a need. They're having a few problems, but for the most part, they're kind of making it. So at that point, the family helps, either leans in, they probably have been up to that point. They can look at private in-home care, and we'll talk about that towards the end. They could consider private pay independent living at that point, and private in-home care. So there's a number of choices that happen. And the family at this time, while that person is still in their own home, may be working towards getting to assisted living, even though they may not qualify for a subsidized bed or anything like that, but they just feel that there's not enough family around, there's not enough help, and that this is just no longer going to work. But so this is that intermediate step between I'm at home, maybe need to be somewhere else. Anything else I should add to that one, Monica?
No, that you've got it covered, I think.
Okay. Next slide is this is the one that rings true for me a lot. And so our loved one is in the hospital. There's been a fall and there's a fracture, and it's not looking like it makes a lot of sense for them to go home. And as the children visit their parent in the hospital, they're kind of going like, I don't know how we're going to do this. So a social worker in the hospital would end up meeting with the family and with your loved one, and they do an assessment to see if the person is safe to return to their home. And so if they are, on the left is the yes. So they may supply home care. And if home care is not enough, reassessment's done to look at appropriate facilities. So they're not just dropped off at home and then you're on your own. There can be still some follow-up. And family may be forced to find a private pay bed while waiting for Fraser Health to sort things out. So this is the messy. This is for sure the messy. Then we have the no. Fraser Health says they can't return home safely. So Fraser Health's going to look for placing the patient within the health region for the required level of care. If a government subsidized bed's available based on a wait list, they would maybe receive that, and it may not be local. And if the family's not satisfied on the far side with it, in-home private pay or assisted long-term care private pay is probably the most immediate solution if there's room in private pay, because sometimes there isn't. So, Monica, do you want to add a little more color to this page?
Yeah, this may not go as easy as ABC 1, 2, 3 sort of thing. On paper, there's definitely protocols and processes, but every situation is different. And I just wanted to also make mention, it's important with the community health nurse assessments that there's family present for those, because sometimes individuals can present really well and can cover really well, and maybe they don't get the true picture. So whether it's in hospital or in home or in facility, if there's a home health assessment going on, I just wanted to make that point, that it's really important that there's family member around to just add to the history there, bits and pieces that maybe the loved one doesn't think to mention. So yeah, this is the tricky one. Even if say your loved one is assessed and has been approved for a government subsidized bed, but like you had just mentioned, there's nothing available. You're allowed to pick several, I think it's 2 or 3 preferred choices to be on wait lists. And in between then you have the option of finding, if you can, a private bed. But like you say, Mark, even the private beds have wait lists these days a lot of times. Or you can look at, oftentimes Fraser Health will say, well, if I put your loved one's name on an interim, it's a shorter term wait list. It's called an interim wait list. It doesn't affect your preferred choices at all, but your name still stays on a preferred choice. But often the interim beds become available a lot sooner because they're not your first choice. And often they're not anybody's first choice, but they're still government subsidized and they are still long-term care. And I know that in some cases, not to alarm anybody, but sometimes people have to look at, the whole sort of region from Boston Bar to Burnaby, which is a little overwhelming. I think this is where our system really needs an overhaul. I know it's hard to say that because it's not ideal for our elderly seniors to be moving around from place to place to place. And sometimes that's what has to happen if they don't have money to, to hire private pay in their own homes until something comes up. So this is a bit of a tricky area.
Yeah, and one thing we talked about just before we got going here with everybody, so somebody is in private pay. Is there any way to get out of private pay into subsidized care?
For sure, if they are in private pay because they've already had an assessment, but there's no availability in a government subsidized bed, then they will be in private pay until a government subsidized bed becomes available. Okay. If somebody's just looking at my mom's not doing well, I need to get her into private pay. Oh, good, there's a bed available. And she's pretty independent, but down the road, you're looking at, her care levels have changed. Again, that's when you make the call to the community health nurse at home health, and they come in and do an assessment. And if indeed, yes, she does qualify for a government subsidized bed, then that happens from there as well.
Okay.
Okay.
Yeah, and I wanted to park here just for a second, because one of the other things too is we talk about private pay. It's like, subsidized bed's not available, we'll just go to private pay. Mark, maybe you could share some of your experience about trying to find a private pay bed on short term?
Yeah, for my mom in the fall, we found a bed. My mom was in the hospital and we managed to find a bed very quickly. And it was like a day or two and we were able to get her into a private pay bed. And then she did better and she moved back to her assisted living. And then another medical event, and we needed to go get into private. And And when we went back to the same place to try to find a private bed, we found out there was 30 people ahead of her on the wait list. And sort of my jaw dropped. I found it quite easy to get in the first time, not easy to get in the second time. And so, but fortunately, I found a different place and where she is now, and it's fine. But it did startle me a little bit. I thought it was going to be a little easier than that.
So what are some of the ways that maybe you could get ahead of this? If like maybe you're in ailing health, like can we put ourselves on a wait list, or like is there ways that we can get think in advance of an event? Because typically when you're in the hospital, it's a crisis and you're now dealing with it and trying to figure out where you're going to go. So what are some of the best practices that we could maybe use about maybe like, when do we enter the system? What is the time to look at those things?
Well, if you have not had an assessment and you're not on a wait list yet, those are, and you're thinking ahead, those are good ideas, for the private facilities like Hallmark and Elim and some of these facilities that you're mentioning. And I know you have slides there that outline the different facilities. It is worthwhile because some of those facilities do have long wait lists. So it is worthwhile, even if you're thinking I'm okay right now, it's always a good idea to, if your money is if that's an option for you, it's worthwhile getting your name on the lists. And with private pay, it works a little different than the government subsidized, where if your name comes up to the top and you go look at it and you're like, I'm just not ready yet, you can just ask them to move take your name off, and you can, I'm not, maybe different facilities manage that a little differently. If you're on a government subsidized wait list and your name comes up and you turn it down, then I know sometimes there's little gray areas here too, but typically if you turn a bed down, your name goes to the bottom of the list again, which, I mean, we all know Mayfair, for example, a government subsidized bed is a 2-year wait list. So, I mean, that's a tricky one. If you turn down a government subsidized bed, that's a different story. But as far as if private pay is an option for you, it is worthwhile thinking ahead and getting your name on some of the lists. And that way you have a choice too, a better choice about which facility. Because when it comes, like in your mother's case, you were probably just looking, and in my mother-in-law's case, it was the same situation. I was like, where is there a private bed available? And I had, yeah. So if you can plan a little bit in advance, of course, if you're on a government, if you are assessed for a government subsidized, that works a little differently. You can't plan ahead of that because you don't know when you're going to be ready for that. You have to have the assessment and qualify, right? So that's a little trickier, but
and we'll talk a little bit more about this in a minute, but I just wanted to touch on it there as we went through kind of the different steps. And so maybe let's jump to what would this cost someone to go about and be in one of these places. And so we've put together kind of option 1, government assisted, and then we've put option 2 is the private pay route. And so maybe I'll let you speak to the government assisted first, then we'll speak to private pay.
Oh, me? Sure. Well, you've got it outlined here pretty clearly that assisted living is pretty much 75% of your income. And residential care, long-term care, private pay long-term, well, not private pay long-term care, residential care is 80%. And I don't know if this is a big deal right now, but with residential care, there are owned and operated sites and there are contracted sites with Fraser Health. And so for owned and operated, everything pretty much is covered with the contracted sites like Mayfair. Some of the medication, if it's not kind of covered under a certain category, then there sometimes people have to pay a little bit extra for certain medications, but otherwise, that includes all the care and everything that you need there.
Okay, so in option 1, that is sort of gives you a rough sense of, so somebody with, because we'll look at if you look at private pay in the bottom, and we'll come back to the top in just a second. So if you had somebody coming in, there's a number of private services where you can have care that comes in multiple times a day or several times a week. They typically have a 2-hour minimum. They charge somewhere between $40 to $80 an hour, and they will help with whatever the activity is, whether that's dressing, bathing, those sorts of things. That sort of gives you a rough sense of sort of cost, and you could And then the assisted living, anywhere from 3,500 to 5,500 would be assisted living for, a single person, again, depending on the level of cares and things that are bolted on, services that are bolted on. And then residential care, anywhere from sort of starting at $6,000 to 10, or even a little bit more. There's places in Vancouver I do know that are running 12 and 13,000, but some of these places, they will actually come and there's basically a chef that'll come to your table and ask you what you want to have made for dinner, but you pay a heck of a lot for that.
Yeah. So we put together some examples of what the costs would look like in getting some of this subsidized funding would be. So here's the first example. So this is Fraser Health post-hospital care. This would be going into assisted living, correct, Mark? Yeah. So Bob has an after-tax income of $42,000. And so Bob pays 70% of his after-tax income. So out of his own pocket, because based on his $42,000 after-tax income, he would pay $29,000 to the care facility. Even if the true cost of care was higher than that, because you saw the private pay, it costs the same to run a subsidized bed as it does for private pay. But the way that our government works and through MSP and Fraser Health and all of those things, you get it at the $29,000 rate. And so that's just giving the people that need care in Canada can get it. And that's an amazing part of our system that we actually can enjoy. And so that works great. And so it is based on your income.
So this is assuming, though, just to be clear, this is if they qualified for a subsidized assisted living bed. Okay, so just to be clear.
Yeah, you got to be medically qualified to be there. So you can't just say, hey, I'm ready for my 70% off retirement home. It has to be assessed and brought you to be there. Also, I want to mention here, let's say your income was much higher than 42,000 and they were going to charge you 70%. So let's say you had an income of over $150,000 on an annual basis as a retiree. You probably would just go private pay, because if they're going to charge you 70% of your income, you'll pay more than you would pay privately. And so it kind of weeds people out of being in that system as they get to higher income levels. Okay, next slide here is the long-term care. Mark, do you want to go through this one?
Oh, again, so this example person has a $60,000 a year of after-tax income, and they on long-term care, they have to pay more. So the other one was 70%. This one's 80% when you're in long-term or residential care. So in this case, this lady's cost is just shy of $50,000 a year, and so it's just reflective of a more expensive care environment.
Mm-hmm. Mm-hmm. Okay, so then we'll jump to the last example that we have here, which is the deductibility of the medical expenses. So this is in the case where you're in a private pay situation and you're paying out of pocket. There is actually quite a bit of medical expenses that you can deduct. So in this case, Frank has $85,000 of income. He would typically pay roughly $11,000 of tax each year. The annual cost of care is $72,000 to be in that long-term care. But Frank can claim eligible medical expenses of $50,400. It's roughly about 75% of the cost of the facility, which would result in him having tax savings each year of about $9,700. So there is deductibility. It's not the same as having a subsidized bed where you're getting 70% paid for, but you're probably bringing your tax near zero just by the amount of medical expenses that you can claim during your income taxes during April of each year. So we'll call that a silver lining. Okay, so then we'll jump to the next slide and kind of transition out of cost.
Yeah. So
go ahead, Mark.
That's it for the sort of the economic side of it. And so now I want to talk a little bit just for a few minutes here as we get towards the end of our time.
Can I just make one more comment about the care? I forgot to mention that things like foot care and hair care, some of those extras, dental care, those sorts of things, those are not included with the medication, the meals, the nursing care. Like those are a little extra. Just wanted to make that clear.
Yeah. Both in private pay and subsidized, correct?
That's right. Yeah.
And so it's kind of like a la carte. You can choose the services that you want and that you need. And some people may go like, I haven't had my hair done in 30 years. Why am I going to have it done here? So I don't want to pay for that.
Mhm.
And some people might go, you know what, this is really refreshing, and I do want that to be part of my daily routine or my weekly routine. And so
Yeah.
it's kind of nice that you can tack some of those things on. So Mark, do you want to speak to some of the legal
Yeah.
documents
So,
that we feel are important for
yeah.
that go along with this stuff?
Yeah. So when you think about, documents that are really critically important, I just can't stress enough the representation agreement that really deals with health issues and matters, and really outlining how I want my care taken, how I want to be taken care of, what I want to have happen, what I don't want to have happen from a medical standpoint. And so our medical system does rely on our input while we are capable of outlining what that is. And representation agreements are relatively straightforward to get done. In fact, on the BC government website, there is even a place where you can pull down a representation agreement, fill the thing out, sign it, and it can be left with your doctor, can be left with your people who could be caring for you. The second document is an enduring power of attorney, and that's a critical document that deals with matters around finance, property, that sort of thing. It is not a document. When you have power of attorney for a parent, you cannot make healthcare decisions with it. So just to be really clear, think of it, it's for money and property, finance. The representation agreement deals with health. And the other document, and this is, Monica, I'll have you speak to the scope of treatment document and what's important about that.
Sure. And just to mention, there's two different types of representation agreements. There's a 7 and a 9. And the 9 is pretty much dealing with matters of health only. The 7 can also actually do with basic day-to-day financial decisions as well. So it's kind of as on par with the enduring power of attorney, which, even though the enduring power of attorney to me is a little bit more of a fuller document, but I do think it's beneficial for people, both of these documents, to actually get them notarized, or by a notary or a lawyer. It's nice to have them very legal, because if there's ever any issues later on, family dynamics do come into play at times. It's nice to have those nice and tight, as when you're still capable and you know what you want. So I just wanted to make note of that. The most is like it says, their medical orders for scope of treatment. It kind of takes the place of the old DNR forms, and it's something that you want to be doing with your doctor. And I know in long-term care, I mean, that gets reviewed every year, where we just look at what would you want as an individual if you get to a point where your health takes quite a severe turn, and say you are not able to discuss at that point. And there's a variety of different scenarios. What would you want to have done? And this is a good opportunity for you, while you're very cognitive still, to have a lot to say there. And if you're not, this is something that when we talk with family members about, what would your loved one want? Not what do you think, what would you like them to, what would you like for them? It's really about what would you like the individual? What do you think the individual would like? So would that person want to, in long-term care, for example, we have this conversation all the time at care conferences, would your loved one want to go to hospital if, they had say a really bad case of pneumonia? Would they want to go to the hospital for IV antibiotics and have to deal with emerge and all that sort of stuff? Or depending on where they are at in their life, what do you think, based on conversations you've had earlier with them, would they want to just be treated on site and made comfortable? And so that's an example of a scenario that document comes into play for. And that's something that, without being in care, that's something that doctors can go over with you at any time.
And you had mentioned that the government website, which is called My Voice, and we had that written down there at the bottom. I could have put the link in there, but you're not going to be able to follow it. It's just so long. So if you search My Voice, there's a bunch of resources on planning work like that.
You can't see that.
You can't see it, but it comes up with a nice PDF, and it's a great checklist, and there's a whole bunch of things in there. So if you're looking for more information on that, I would recommend checking out the My Voice area. So let's transition to critical conversations with family. So we've talked about all the options that are out there. And so what does it actually look like for us to be having these conversations with your kids or with your parents? And so often there's one party in that relationship that wants to talk about it. Maybe I don't want mom and dad to get old and I don't want to talk about this, or it's mom and dad, or I'm not old and I don't want to talk about me getting old. And so what are some of the best ways and when is the time to talk about this? Mark, why don't you start?
Yeah, it's I guess nobody looks forward to having these conversations. Like this isn't a thing, but if we care about our family and we want the best for them, it means that we are going to sometimes to have conversations that perhaps are a little bit more difficult and not the easiest. They will be easy for some people, less so for others. And I think it's often a conversation that maybe isn't just had in one sitting. It's a conversation that started and then it's returned to over a period of time to ask and find out, what are the things that the parent wants to have happen? What things don't they want to have happen? How do they want to be cared for? Who do they want their care to be, their primary caregiver outside of a care facility to be? And really understanding what those their needs are, and from that might be from the senior, for the child is really concerned perhaps about their parent and saying, we need to have a conversation about what we want to understand what you want, and so it can go both ways, and one of the parties needs to sort of lead the dance and just begin that conversation. And I don't think it's a conversation that needs to be forced or anything on anybody, but these things are going to happen one way or another. And as we age, there's going to be things that happen that we didn't sign up for, but it will be there. And either it's happening and decisions are being made, at a bedside in a hospital, or maybe they're being made well in advance of that. And so everybody's clear on it, and you're not having to deal with that sort of in the heat of the moment about, boy, we can't go back home. Now we got to go here, but we never even looked at any places. I have no idea where my mom or my dad should be going. And wouldn't have been good like 5 years ago that we should have done a drive around and had a little bit of a look at this. And then, and so, when do we have this conversation? Maybe it's just with one or two of the kids, perhaps with the parents. Maybe it's just one of the children who is the best person to have that conversation with. And so, it's a variety of ways. And so, as we think about the next slide, it's really about there's steps to this. And as we think about seniors and aging, first of all, we need to understand and think about what are all the things that could happen, and what would that mean for me? What are some of the things that I'm going to have to understand about levels of care? And this, just by you all showing up on this, says that you're prepared to think about this, learn about it, realizing
Gold star.
Decisions to be made about this, a conversation that needs to be had about all of this next levels of care, and making some notes about it so that you can reference it later. Because sometimes these conversations happen and then nothing, you don't have to revisit maybe for a number of years, and you go, whatever happened to that discussion? What did we decide again? And so I just think that anytime you can write something down and maybe even make multiple copies of it, so you've got one, your parent has one, and it becomes a great reference tool.
Yeah, and I think that one of the things I always like to remind people that are getting to that spot in life is you can either make these decisions for yourself or someone will make them for you. And so I always encourage people that are getting into their mid 80s, they've been healthy all the way through. Like statistically, after that, like something breaks down eventually, and it might be an accident. You might have just tripped and suddenly you're dealing with a broken femur, and that spurs on a care situation. If you haven't thought about it in advance about what places do I want to go? Where are my friends? Is this local? Like, what local spots are near me that I would want to be, that I'm close to family? Do they offer the services that I want? Does it align with the values that I have? And I think that as you age, to go and tour around, figure out what's out there. what are the places that are available, and does any of them kind of stick out to you? I would like to go there if I ever had a problem. And doing that in advance of a crisis is just so important. And like we talked about earlier, you can put your name on a list. You don't have to take it, but if it ever came to it, you'd love to have your name at the top of the list, especially when it comes to couples. If you guys want to move into care together, there's a lot less two-bedroom or like couple rooms compared to single person rooms, or 2-bedroom places are very sought after. And so being on a list in advance for kind of those premium rooms is super great. And so I think when you take charge of it on your own, you only do yourself favors.
And I think that most care facilities too, they offer opportunities to tour them and to have a look at what services are provided. And so it's when you show up and say, hey, I'd like to knock on the door and see what this would look like. From our experience, different care facilities are they're willing to share that. And I think that just, you should take that opportunity to do that.
Okay, so I'm going to ask Monica, I'm going to ask you kind of one last question here before we get going towards the end of this. And so you live this every day. You watch people come in the door, and their families come in and help them get settled and walk through this whole thing. If you had to say, like, what are the best situations or the best practices that you're seeing? You know, I wish every family was like that. Like, what are the things that you can kind of pinpoint as the things that someone could walk away from tonight's meeting and going, okay, I can work towards that?
Well, honestly, in an ideal setting, the individual themselves would be thinking ahead of what this might look like, not only just for them, but for the family. And so they would already be taking the initiative themselves. I think that the individuals that, you know, take the bull by the horn and think about what that might look like later for them, that's best case scenario. And then with the family, I think it's really good. I mean, honestly, if there are many children, that can be a big help sometimes, because one naturally becomes more of, say, the nurturer, the caregiver. One naturally maybe lends more to the financial side of things. One naturally lends more to shopping or getting things set up, maybe room decor in a long-term care setting. So I think that is another piece, that if the family can look at it and you know, think of what they can best you know, give to the situation, I think that helps too. So everybody's not, you know, clamoring after the same thing and wanting the same thing. And I think a key, I mean, you guys did a great job of describing it all there and explaining it. I think key is always thinking at the core of who, you know, what's best for the individual or individuals, and what do they want? Because it may not be at all what you want. I mean, we know of, as a social worker and working in different angles of this, I have known different people who have lived at risk before, but they have had the mental capacity to make that decision. And it's hard then for some family members because they don't like maybe how that looks. But so yeah, I think that's, in an ideal setting, the individual themselves is initiating, and the family is very open to understanding and listening to what that person wants, and then looking at where their strengths lie and how they can best help out. Yeah, and amazing. Like you said, Mark, earlier, I think the earlier these conversations start, the better. Ideally, it's not just a one-off, it's over the course of time. And I mean, sometimes time is a luxury. If there's a major health event like a stroke or something, right, and there is no time, those situations happen as well. But in an ideal setting, I think you guys covered a lot of the basics.
Okay.
Perfect. Okay, so we're going to get to our last couple slides here, and then we're going to wrap up. And so we just have a couple of pieces of key information. So in the these are some of the places that have subsidized beds. And so I'll just let you, as viewers, just to scan through it. You might recognize a few names there. So those are the places that would fall under having government help on the finance side of things. So that's Langley, Mission, Abbotsford, Chilliwack, Agassiz, Hope. And then a little bit further out from this area is Burnaby, New Westminster, Tri-Cities, Maple Ridge, Delta, Surrey, White Rock. And so you can scan through this, and if you don't see exactly what you're looking for here, you can always play this back. And so I also threw on this slide the 100 number for home health services phone line. So once again, Monica, can you just say what that number is?
That is the service line to home health, so that if you're not at all, if you've not at all been assessed by the community health nurse yet, or or if in the hospital, the hospital liaison, and you're thinking, my mother needs some home support, I think I need to look at that. This is the number to call to make the referral. Yeah. And if you're already, once the referral is made and you've had the assessment with the community health nurse, then that health nurse will give you the phone number for the actual home health office. And then from there on, you can just speak direct, you can call directly to the home health office, but this is the referral line.
Okay,
Mm-hmm,
great.
Mm-hmm. Perfect.
Second last slide here is just for private in-home care. So these are 4 different services that exist in our area that you can again reach out to. Everything from meal support to, it's a full suite of services, and it's really as much as is required. And so these are, where maybe the kids are really involved, but they're needing a little extra help. This may be it. There might be no kids involved, but as a senior is saying, hey, I need somebody to help with some meals. So there's an option here. So these, again, if anybody wants to reach out to us, we're happy to pass that along.
Yeah, and some folks actually, they do receive home supports, but they also augment with private care as well, because of there's different reasons for that.
Yeah.
I recently heard of somebody who has respite help through home health, and that worker doesn't do a whole lot other than companionship because of the different standards and different policies and stuff that they follow. So then they hired private help to come and do, more personal care and that sort of thing. So people sometimes use both very nicely together as well.
Yeah, and there is no one set recipe. That is what I know for sure. Like, I've seen everything from where somebody has somebody living in their basement, and then a little bit of home health, a little bit of other private, and you have to figure it out for your own family, for your loved one, what works. And but these are a pile of resources here that sort of paint the picture of what supports are there. And so what our goal really with tonight is to give you, where do I grab on when something happens, and how do I be proactive about it? And we believe that from a planning standpoint, being proactive and getting ahead of these things, that's where the best decisions are made, not in the heat of the moment, and we're going to have the best outcomes. So as we age wherever we're aging, it's going to happen in the best way possible to give, dignity, peace for the person, joy, and for the loved ones, knowing that the parent is really being well taken care of. And so that was really the goal of tonight, is just to share that. And so I really appreciate you, Monica, for you being along, and awesome that you could. I know in our email out we said that it was Dina Littlejohn was going to be from one of her partners was going to be in on this, but it didn't work. She was dealing with a parent health emergency of all things, so we're all in the thick of it together here. So was it, Brent, did anybody have any questions that
I haven't had any questions come in? I'll give it maybe 30 seconds here. If you want to, you can either type it in, or you can even raise your hand with the Zoom app, and I could give you the ability to speak. So on behalf of our whole team, I just want to thank everybody for joining us. This will be available as a recorded webinar. And so if you want a recording of this to maybe send to someone else, or to be able to watch back because you maybe missed something, just send an email to Kelly on our team, and she could send that out to you. I think we'll also post it on our YouTube channel for Driediger Wealth Planning, so you can find it there as well. So that's what's going on there. I also want to thank Kelly for helping us with the presentation. She worked hard on it today too. And Monica, for joining us, and I want to thank all of our clients for just being a part of our lives, and we enjoy working with every single one of you. And so if anybody has follow-up questions or wants a personal conversation after this, please do let us know. I got a hand raised. Okay, so we're gonna try to see if we can bring him in here. Give me 1 second, Wayne, while I work on that. All All right, Wayne, you have the floor. Go ahead and ask a question.
Sorry, I was trying to write something in the chat to say thank you and I hit raise your hand. So,
Oh, okay, no worries, no worries.
but anyway, it's a great presentation. Really some good food for thought.
Awesome.
Appreciate that.
Amazing. Oh, thank you for that. Appreciate it.
Thank you.
Yeah.
You're welcome. You're welcome. All
Okay.
right. Ron and Ruth Berg have a question. Okay, let's give them, so give me a second. I will let them ask a question. Ron and Ruth, you have the floor.
Maybe you said this earlier, but has this session been recorded?
Yeah.
Yes, it has. Yeah, we
Okay,
can
and
get
how
that
do
sent
we,
out to
how
you.
do we get it and where will it be available?
We'll have it on YouTube and we can also email it to you, okay?
Okay, that'd be
Yeah.
great. Thank you very much.
Yeah.
Yeah, no worries at all. No worries at all.
Much appreciated. Good session.
You're welcome.
We'll have to move back to BC.
Okay, okay, yeah, I'm gonna have to give you an Alberta-centric one.
Okay. It's 8 o'clock and we wanted to keep it at an hour. So I think we'll wrap it up there. Monica, again, thanks. And all of everybody who joined us this evening, it was awesome to have you here. And thanks for being part of this. We appreciate this opportunity to share.
Okay.
I'm very impressed that you guys are doing this. I think this is great because there is a lot of kind of confusion out there as to how this all works. So kudos to you guys for setting this up.
Yeah, awesome. Okay, thanks
All right, everyone. You have a great night. Enjoy your
Good night.
Tuesday.
Bye-bye.
Bye now.